السلام عليكم. الصوت واضح؟
وعليكم السلام ورحمة الله.
Today I'll speak about a primary Cns Vasculitis in children and the general approach to this problem. We mean by primary Cns Vasculitis, it's a vasculitis that affects solely the CNS vessels, intracranial vessels. So my objectives to review a basic approach to evaluation and treatment of primary CNS vasculitis in children, and to understand, and I want to stress this point, to understand the importance of multidisciplinary team approach to evaluate and treat such condition. This condition is a relatively rare condition. However, it's easily underdiagnosed or overlooked. If it is missed, it leads to a devastating outcome. A good outcome associated with early recognition of this condition. And early recognition mandate multiple subspecialties involved in this condition, namely a neurologist, neurosurgery, neuroradiology, psychiatrist, and in terms of management, other general pediatricians, also occupational and physiotherapy, and many subspecialties, diagnosis, in addition to nurses, to good laboratory setup. So, in fact, during my training, there was a huge team dealing with this condition. So it's not just only related to just a rheumatologist. Most of the subspecialties involved in this to reach to a diagnosis, because in fact it's difficult to diagnose, and sometimes it's not surprised that afterwards, after like 1 to 2 years of immune suppressive medication, you recognize this, it may be another diagnosis. A primary CNS vasculitis is a category of inflammatory diseases characterized by brain dysfunction, and this is secondary to autoimmune mediated process. It's a leading cause of devastating neurological deficit or neuropsychiatric syndromes in previously healthy children. Sinus vasculitis could be a primary disease where we don't have other evidence of vasculitis in other vessels outside the CNS, or it could be secondary to underlying cause, and we'll come to all of these. It reflects dysregulation of innate and adaptive immune system. Inflammatory brain disease composed of multiple diseases, including CNS vasculitis, which is the main subject for today, demyelinating diseases, T-cell associated parenchymal inflammatory brain disease, and the good example for this is Racine encephalitis. The neuronal antibody-associated inflammatory brain diseases, and this includes many diseases and so many and ongoing discovery of these diseases, like anti-NMDA encephalitis, neuromyelitis optica, limbic encephalitis, etc. So the general approach for autoimmune brain diseases, when we exclude, when we diagnose this patient as having like inflammation, so we have to differentiate it from non-inflammatory diseases. So if this patient is having evidence of inflammation, it's either infection, malignancy, or autoimmune disease. So if we after ruling out the infections and malignancies that causes the inflammation, we left with autoimmune brain diseases. And this is divided mainly to CNS vasculitis. I don't know, do you see the mouse moving? Do you see the mouse?
Yes, we do.
Okay. So CNS vasculitis, it's either primary CNS vasculitis, and we mean by primary that it affects solely the brain blood vessels. And this is also divided to angiography negative and angiography positive, and we will come to detail for this. Or secondary CNS vasculitis, and this could be related to Behçet's disease, to sarcoidosis, to systemic vasculitis, lupus, antiphospholipid syndrome, or maybe secondary to infection like meningitis or viral encephalitis, or could be related to like TB. TB could give you a CNS vasculitis, or encephalitis, and the encephalitis divided to demyelinating diseases, which include now ADEM, multiple sclerosis, neuromyelitis optica, spectrum disorder, anti-MOG antibodies, or autoimmune encephalitis, either intracellular antigen, which include GAD and other paraneoplastic antibodies, or cell surface antigen, and the good example for this is NMDA receptor encephalitis. So we'll speak or we'll go specifically to CNS vasculitis, and the CNS vasculitis could be, as I say, the primary or secondary. The primary CNS vasculitis, it was discovered initially, or the first case reported on 1959. This is the first case discovered, and the diagnosis was based on autopsy. It remained until 1988, where Calabris, he's an adult rheumatologist, currently working in Cleveland, Ohio, USA. So in 1988, Calabris put the a diagnostic criteria for primary CNS vasculitis for adults, which include a newly acquired, otherwise unexplained CNS symptoms, angiography or histopathology features of CNS angitis, and no systemic associated disease. And then in 2006, Pensler, who's a pediatric rheumatologist in children, she modified this to a newly diagnosed neurological or psychiatric symptoms, and the age limit less than 18 years of age, with angiography or histopathology features of CNS vasculitis, and excluding other secondary causes. So primary angitis of the CNS, this is the other name of the primary CNS vasculitis. It's divided to angiography positive, where in fact the diagnosis is mostly done by a clinical laboratory and also by the radiological study. So we put a huge weight on the radiologist for the diagnosis of angiography positive CNS vasculitis, or angiography negative, where it involves the small blood vessels. The small blood vessels, it's difficult to be seen in angiography. So it's a vasculitis affecting the small blood vessels, and the diagnosis is based on biopsy. So this is the main blood vessels of the brain, internal distal part of the internal carotid, and the middle cerebral artery, the anterior cerebral artery, and the posterior basilar artery, and the posterior cerebral artery. And in the peripheries, where the small vessels, this is where patients having angiography negative, if it affects the small vessels, and it's not clear by the angio. The angiography positive, now I will concentrate on angiography positive CNS vasculitis. We divide it to two categories, to a progressive primary CNS vasculitis or non-progressive. And the division between progressive and non-progressive, it's depend mainly on MRI after 3 months of the onset of the disease. And we compare the first MRI with the second, which will be done after 3 months. If there is a progress with more involvement of vascular beds, this indicates it's a progressive CNS vasculitis. So I will speak first about a progressive primary angitis of CNS. Usually the patients, it could affect any age. Probably the youngest I saw in the literature, almost less than 1 year of age, till 18 years of age. So patient present usually with headache, cognitive dysfunction, focal and diffuse deficit. Diffuse deficit we mean by decreased concentration, decreased school performance, problem with memories. This disease could be, or mostly is insidious, and it's more in boys. The angiography positive in general more on boys. The angiography negative, which is a small vessel vasculitis, more commoner in girls. Inflammatory marker and the progressive subtype increase in almost 50%. What we mean by inflammatory marker, we mean the peripheral blood inflammatory marker, which include ESR, C-reactive protein, or von Willebrand antigen. Von Willebrand antigen, it's an inflammatory marker, as well as it is stored in the endothelium of the blood vessels. So if patients have vasculitis and damage of the endothelium, the von Willebrand antigen will raise in the peripheral blood. Also, inflammatory marker includes in the CSF include protein, include WBC, and also if there is high opening pressure, this is indirect way which may give like an idea, maybe there is an inflammatory disease. The MRI and the MRA, it showed multifocal bilateral lesions, and it's inflammatory or ischemic, and it's usually gadolinium enhanced lesions. So we use also the vessel wall, a type of a study called vessel wall enhancement, and usually in those cases it's enhancing. The enhancement, it means there is probably an edema, and this is indirect evidence of inflammation. The angiography also, it showed distal and proximal bilateral multiple stenosis. compare this side with this side, you will see it's enhancing and giving more bright color here. So this is the visual wall contrast enhancement, and this is indirectly indicate probably most likely this patient is having inflammation. The problem with the angiography positive CNS vasculitis, it affects medium and large vessel. Medium and large vessel, you know, the gold standard usually in vasculitis for diagnosis is biopsy. But in medium to large vessel, you cannot, or it's difficult to take biopsy because of the risks. Patient will be more risk for bleeding, especially in inflamed blood vessels, and more risk also to stroke. So because of those complications, we diagnose the medium and large vessel vasculitis indirect. So we are looking for any evidence of inflammation, either a radiology or an investigations. While in small vessel vasculitis, which we will come to it, it's based on tissue biopsy where you see the vasculitis or the inflammatory cells infiltrating the blood vessel wall. This is again a gadolinium contrast inflamed vascular bed. You could compare this side with this side. So you would see this is more enhancing, and this is indirect way that this blood vessel most likely inflamed. So it tells us that the blood vessel inflamed. Then it's our job to exclude other secondary causes. And the angiography, the radiologist better than me in explaining this, it will show the multifocality of the stenosis. Probably you could see it here, and also in the distal branch here, also here. So you would see multifocal proximal and distal arterial vessel stenosis, and maybe obliteration of the blood vessel if the disease is advanced in that blood vessel. The treatment, and because of the nature of this disease and because of its progression, we treat this with high dose, long duration of steroid from 6 months to 1 year. We give them a chemotherapy like cyclophosphamide for 6 months, and then followed by mycophenolate mofetil for another 18 months, or azathioprine if the patient have like side effects to MMF or didn't improve in the appropriate way. Plus the antithrombotic therapy is recommended as secondary stroke prophylaxis. Antithrombotic, you could give either aspirin, or some people they will give anticoagulation. Some people they will give anticoagulation at the beginning, then followed by aspirin. Complete neurological recovery in the subtypes around 45%. So this is in regard to progressive CNS vasculitis. For non-progressive CNS vasculitis, this term also been used by our colleague in neurology as transient cerebral angiopathy or focal cerebral arteriopathy. It seems to be all of these names denote to the same condition, which is non-progressive primary CNS vasculitis. Some subset of patients, this angiopathy or arteriopathy, it preceded by varicella infection. So it's called in the literature under post-varicella arteriopathy. And this is usually patient will have in the history chicken pox in the preceding 12 months. So in this subtype, the usual clinical manifestation is universally stroke, sometimes associated with headache. Rarely patient will have a neurocognitive dysfunction or seizure. It's more in boys. Inflammatory markers universally in this subtype is normal. So if you do ESR, C-reactive protein, or CBC, it would be normal. Also the CSF studies are normal. So the diagnosis in this subtype is based mainly on the radiological study, and is based mainly on our colleagues on the radiology. Usually, the subtypes affecting unilateral, distal part of internal carotid and proximal part of the middle or anterior cerebral artery. So it's unilateral, unifocal, diffusion restricted lesions, which indicate ischemic lesions, and it affects the proximal part. And it may show gadolinium enhancing visual wall. And this is probably indirect way that this blood vessel is inflamed. And the angiography, it will show the involvement of the distal part of the internal carotid and the proximal part of anterior or middle cerebral artery. And classically, it showed the stenotic lesions. This is the MRI finding of parenchymal lesion, unilateral, unifocal, and it's a restricted diffusion image. So it probably indicate there is ischemic lesion. And here probably if you could see the right middle cerebral artery stenosis at the proximal part before the first branch. Again, unilateral middle cerebral artery with multiple areas of stenosis. Probably you could see it here clear, with narrowing of the right M1 and M2 segments. And some subset of patients associated with varicella, and there is a hypothesis, the virus hypothesis, where the varicella after chickenpox infection, it remain latent in the trigeminal ganglia. And because the blood vessels are in close proximity to the ganglia, so what happened, the hypothesis that the virus will invade the blood vessel, the endothelial and smooth muscle, and causing inflammation and subsequent vasculitis. Here is a histopathology from the MCA cross-sectional, where it showed stenosis and infiltration of the middle cerebral artery by the inflammatory cells. And immunohistochemistry, sometimes it shows evidence of varicella zoster virus antigen, especially in those patients having post-varicella arteriopathy. This is a post-mortem biopsy. So how to diagnose this? By sending the CSF for PCR or for antibodies to varicella, plus the suggestive history of chickenpox in the preceding 12 months. The treatment, steroid, some in fact people give steroid in the acute stage, those who believe this is secondary to vasculitis and inflammation. Antithrombotic medication, usually anticoagulation at the beginning, then followed by aspirin. And it's in fact depend on the degree of stenosis of the blood vessel. It was found in a small study that steroid might prevent recurrent ischemic attacks, because those patients, they have high rate of recurrence of the stroke or the ischemic attack because of the narrowing of the blood vessels. And it was found in a small of patients that it improved the long-term neurological outcome. And the complete neurological recovery, it happened in only 30% of patients. And why is that? Because this will result in ischemia, which means a permanent damage. Before diagnosing medium or large vessel angiography positive CNS vasculitis, we have to exclude the mimickers. And the mimickers that could mimic large or small or medium vessel vasculitis confined to the CNS, arterial dissection. And this could be diagnosed by neuroradiology study, where it will show the intimal flap. Also, we have to exclude thromboembolic diseases. Thromboembolic diseases, sometimes it could be also secondary to vasculitis. We have to exclude fibromuscular dysplasia, where those patients have stenosis of their blood vessels, multiple stenosis, like a streak impede. And this is non-inflammatory disease and does not require immune suppressive. It's sometimes really very hard to differentiate from primary CNS vasculitis, but probably gadolinium enhancing blood vessel will help in this. Moyamoya disease also, it's a great mimicker, as it affects on the same way of large vessel CNS vasculitis. It affects the distal part of the internal carotid and the proximal part of the medium and middle and anterior cerebral artery. Sometimes it's quite difficult at the beginning to differentiate between the two. Gadolinium enhancement sometimes seen in patients with moyamoya disease. In moyamoya disease, some patients, they may have rim of vascular enhancement. So sometimes really it's quite difficult to differentiate between these two conditions. Von Willebrand, it may help in this matter. And the course of the disease also will help. Because moyamoya disease, we know it's a progressive disease. Vasospastic disorder, especially reversible vasoconstrictive syndrome, also is another differential. And we can differentiate between reversible vasoconstrictive syndrome and large or medium vessel primary CNS vasculitis by the same thing, by vast vessel wall enhancement. And also, if you do the MRI after or angio after 8 to 12 weeks, you will find the resolution of the stenosis and reversible vasoconstrictive syndrome. We have to exclude other channelopathies, especially calcium channelopathies, and this is can be by gene studies. Hemoglobinopathies, especially sickle cell disease, post-radiation vasculopathy could give the same features. Other connective tissue disorder like neurofibromatosis, Marfan syndrome, Ehlers-Danlos, and some also metabolic disease, especially those associated with thrombosis. So we have to rule out all of these before labeling the patient as having medium or large vessel primary CNS vasculitis. Now we will, sorry, I think there is one slide. So now we will go with the second type, which is angiography negative CNS small vessel disease. Why angiography negative? Because it affects the smaller blood vessels and it would be hard to see it in the angiography studies. Those patients usually presented with seizures, with focal and diffuse neurological deficit, and sometimes psychiatric symptoms. It's more in girls. The good thing about this subtype, that the diagnosis or the evidence of inflammation is higher than the angiography positive. So you will find raised inflammatory marker in more than 90% of patients. And this could include ESR, C-reactive protein, WBC, or CSF study protein in the CSF, high protein or high WBC. Usually the WBC in the CSF is mildly elevated. If we see a high WBC in the CSF, especially if it is more than 100, we have to exclude or go more vigorously to exclude and more vigilant to exclude other differential or other secondary causes. Oligoclonal band in 30% of patients. The MRI usually showed white and gray matter lesions. It's not restricted to vascular territories. And leptomeningeal or lesional enhancement, because this type of vasculitis is inflammatory more than like in the large vessel where it gives an ischemic lesions. The angiography usually normal, and it's the diagnosis of this condition only done by intramural or perivascular lymphocytic infiltrate. Please can you mute all the there is a noise, so please make sure that your side is mute. The ultimate diagnosis is by intramural and perivascular lymphocytic infiltrate. The great mimicker of this, or before the mimickers wall, this is the usual or the MRI finding that could be seen. You could see leptomeningeal enhancement. Why leptomeningeal enhancement? Because we know that the meninges is rich of small blood vessels. So patients with a small blood vessel primary CNS vasculitis, they tend to have meningeal enhancement. And also white matter enhancing lesion like in this patient. And brain biopsy, typically it showed intravascular, this is the blood vessel wall, and there will be an infiltrate of lymphocyte, monocyte, and macrophage of the blood vessel wall, and giving a secondary reactive changes and causing probably damaging of the blood vessel. Or maybe a perivascular lymphocytic infiltrate. And the perivascular lymphocytic infiltrate, especially we do see it in patients who already received the steroid. So the problem that the diagnostic yield for brain biopsy is 69%. The biopsy, it should be a full thickness brain biopsy. Non-lesional biopsy, especially in those patients who have a deep lesion where you cannot go and take biopsy. So non-lesional biopsy is recommended from non-dominant temporal or frontal lobes, and the yield of non-lesional biopsy is around 45 to 50%. The treatment of the small vessel vasculitis, because it's a devastating disease, because it's associated with, in fact, it's more than the large and medium vessel in association with bad neurocognitive outcomes. So it should be treated with a steroid, and the steroid be tapered over 1 year. We give cyclophosphamide 7 doses, 1 dose each month from 500 to 1 gram per meter square per dose, and then followed by mycophenolate mofetil or azathioprine for another 18 months. And if the patient have like remission, we could wean the medication gradually. If the patient still have active disease, we may change the medication and give other immune suppressive medication. The complete neurological recovery, probably you'd see it here, is higher than the medium and large blood vessels. Why? Because this is inflammatory lesion where you have a medication, anti-inflammatory medication that improve the outcome. In the large and medium blood vessels, it results in mostly in ischemic lesions where it's a permanent damage. In secondary CNS vasculitis, you have to rule out secondary causes. And this is especially infections like Mycobacterium TB. During my training, I saw 1 patient with just only isolated CNS TB. And that patient presented with a feature of CNS vasculitis in imaging. And he had like a PBD, positive PBD skin test. The WBC in the CSF was quite high. as far as I remember, around 400 WBC mainly lymphocytes with high protein. And the PCR in the CSF was negative at the beginning. The brain biopsy was done and it showed the typical CNS vasculitis, small vessel vasculitis. And the brain biopsy was sent also for cultures, including TB, and all of them were negative. This patient was treated as primary CNS vasculitis, but after, and he improved, in fact, at the beginning. But after the second dose of cyclophosphamide, this patient deteriorated. And when we repeat the CSF study, the PCR for TB was positive. So TB, it could present like as small vessel vasculitis, or it could present, or some patient may have stenosis of the large blood vessels. Also mycoplasma pneumoniae, strep pneumo, and other virus causes, fungal causes, other inflammatory and autoimmune, especially Behçet's disease, lupus, Sjögren syndrome, other systemic vasculitis, inflammatory bowel disease, and also familial hemophagocytic lymphocytosis. Familial hemophagocytic lymphocytosis could present solely affecting the CNS without peripheral evidence of hemophagocytosis, like the labs of hemophagocytosis, like some patients, they have normal ferritin, normal inflammatory marker in the peripheral blood. And also the biopsy, it may show vasculitis. And those patients diagnosed sometimes by genetic study. We had with our colleague in neurology a few patients like this. Other also diseases like drug-induced CNS vasculitis, graft versus host disease, should be also, you should make sure that has been ruled out. The also great mimicker of the primary small vessel CNS vasculitis is demyelinating diseases. And it could really look like, and especially in imaging or laboratory, look like small vessel vasculitis. Von Willebrand usually high in small vessel vasculitis, and it's normal in demyelinating diseases, especially ADEM. And also the meningeal enhancement, usually in CNS vasculitis and not in demyelinating disease, and this could give a hint. However, the absolute, you could make sure that if you want to differentiate between the two by brain biopsy. The clinical phenotype overall of the primary CNS vasculitis, some patients, they may present like feature of NMDA neural antibodies with encephilitis like phenotype. Other patient with present with like encephalitis and demyelinating subtype, and angiography negative primary CNS vasculitis could mimic all of these. The angiography positive, they present usually with stroke-like phenotype. And this is again the stroke phenotype, usually in angiography positive primary CNS vasculitis. The encephalopathy phenotype in angiography negative small vessel vasculitis, anti-NMDA receptor encephalitis, post-infectious inflammatory brain disease, and also the encephalitis or encephalopathy with impaired vision, which happened again, it could happen in angiography negative primary CNS vasculitis and in non-NMDA related neuronal antibody encephalitis. And after history and clinical assessment and laboratory for the stroke phenotype, MRI, visual wall imaging, and conventional angio could give you the diagnosis. And encephalopathy in a cluster 2 and 3, we do neuronal antibodies. And if the neuronal antibodies all are negative, then we will go for brain biopsy if we have MRI lesions. So the usual workup for patient with CNS vasculitis, usually we send those patients for ophthalmology exam. It could help you in like demyelinating disease or in excluding other secondary vasculitis like uveitis in patient with Behçet's disease. CBC, differential ESR, C-reactive protein von Willebrand factor antigen. CSF, we ask for opening pressure to calculate the opening pressure, the cell count, protein, glucose, oligoclonal band, and various antibodies for autoimmune encephalitis, plus cultures and PCR to rule out infections. And also ANA and other lupus antibodies complement to rule out or exclude lupus as secondary vasculitis. ACE may help, sometimes may help in like sarcoidosis, although the gold standard is the biopsy for diagnosing sarcoidosis. And we know that sarcoidosis, it could present only affecting the CNS. ANCA and antiphospholipid antibodies. Also infections, brucella serology, TB quantiferon, and then the radiological studies, MRI brain, MRA, and visual wall study. And then conventional angiography, because this is the gold standard for large and medium visual vasculitis. And if patient is having an evidence of inflammatory disease with MRI finding and we could not reach to the diagnosis, then we'll go for brain biopsy. The normal opening pressure in pediatrics is up to 28, and this pressure may increase to up to 3 with sedation. Opening pressure, it indicates increased intracranial pressure, and this is maybe related to inflammation. In terms of MRI, if you have like abnormal MRI in patients suspected to have CNS vasculitis or autoimmune encephalitis, you will go for visual imaging, including MRA, MRV, or angiography and visual wall studies. This patient or those patients, they may have angiography positive. If they are angiography positive, then the diagnosis of angiography positive CNS vasculitis. If they have angiography negative, then we'll go to another category with patients who have usually normal MRI, and this is frequently happen in autoimmune encephalitis, especially those who have antineuronal antibody positive, especially anti-NMDA. Or patients may have like a demyelinating features, and this is also could be diagnosed by sometimes by anti-neuronal antibodies like anti-MOG and neuromyelitis optic antibodies. Or anti-neuronal antibody may be negative, so in this case we'll go to brain biopsy. If the brain biopsy is negative, this is maybe autoimmune encephalitis. If it is positive, this indicates that this patient may be having angiography negative primary CNS vasculitis. This is the brain biopsy in a patient with anti-MOG. Can also show lymphocytic perivascular infiltration. So the practice is to wait for MOG antibody testing prior to go for the invasive procedure like brain biopsy. Despite that, the brain biopsy is really a very safe procedure, and it's really extremely helpful in those cases. I will speak about two autoimmune conditions because they may affect only the brain, and they may mimic CNS vasculitis. So neuroBehçet, it could present either involving a blood vessel, especially sagittal sinuses, where patients, they could have sagittal sinus thrombosis, or it may be parenchymal. So in patients with parenchymal, commonly they have headache, confusion, or behavioral changes, and fever. In terms of labs, the CSF will show elevation of protein and WBC. And the MRI usually abnormal in 75%, and it has a predilection for brain stem and hemispheres. EEG usually normal in Behçet's disease. Usually Behçet's disease, they do not have seizure because the lesions, parenchymal lesion affecting the deep areas in the brain stem and hemispheres. I mean not the cortex. The other mimickers is a neurosarcoidosis. And patient, they could present with only isolated CNS neurosarcoid in 5%. Patient, they may have encephalopathy, headache. They may have also optic neuritis, and also patients with neurobehçets, they may have optic neuritis as well. They may have hearing loss and facial palsy. In blood, it may show elevation of the ESR with also CSF study showed elevation of WBC and the proteins. Oligoclonal band may be detected in 20%. Also, maybe there will be elevation of serum or CSF ACE, angiotensin converting enzyme level. And the MRI finding, it affects the leptomeninges, like what happened in small blood vessels disease, usually non-enhancing. It may present like a parenchymal mass-like lesion as tumors. And the biopsy in those patients will be very helpful. It may affect pituitary or hypothalamus, and it could be isolated to the CNS, and it could mimic neuromyelitis optica spectrum disorder. So now I finished my presentation. Now we will go to, before going to a case scenario, is there any question so far? In the case discussion, it's my turn to ask you. So before going to the case discussion, is there any question, you could write it in the chat. We'll give probably a few minutes if you have any questions. And some of the question I may not answer it, I may refer it to some audience, my neurology colleague or pediatric neurologist colleague, because it's, and also if there is any neuroradiologist or pediatric radiologist. Any question? Okay, is there correlation between the type of stenosis in angiography, if it's sacral or single, and the cause of inflammation? Not really, not really. How common brain biopsy to be negative? Yeah, brain biopsy and the small blood vessels, the yield for brain biopsy from the lesion 69%. So you have 30% negative brain biopsy and a small vessel disease. And non-lesional biopsy, the yield of it between 45 to around 49%. So you have 50% that it could be negative, and the patient still have primary Cns Vasculitis, small blood vessel primary Cns Vasculitis. Is there a classic symptoms that should make red flag to look for vasculitis, since there is, yes. Unfortunately, there is no classic symptoms. Usually in the non-progressive large blood vessel, patient will present with a stroke. So you have to take all the differential diagnosis of stroke. And in fact, the progressive CNS vasculitis, it's a diagnosis of exclusion plus supportive finding in the angiography. The same thing for the small vessel vasculitis. It's really extremely difficult to just based on a clinical or even laboratory to differentiate between the two. So you have to put a long list of differential diagnoses to exclude, and then you prove this if it's small vessel by brain biopsy. And the brain biopsy is really very safe. It's done a lot. I didn't remember one patient have complication. And the usual complication is just the regular wound complication, which happen for any surgery. Would you like to repeat how to differentiate between a progressive large vasculitis and moya disease? Thank you. Sometimes it's really extremely difficult. I will tell you one story of our patient. And this patient, in fact, he had, he went also to USA, to Johns Hopkins, to take another opinion, and almost both opinion are almost the same. This patient presented at the age of around 4 years of age with a stroke, and the MRA showed narrowing of the distal and proximal part of internal carotid, including the cervical part of internal carotid. And this stenosis extend to the middle cerebral artery, the proximal part of middle cerebral artery. And it affects both sides. However, this patient, when we did a visual wall enhancement, there was a long segment visual wall enhancement, which indicate probably it's related to inflammation. His all other inflammatory markers were normal. However, his von Willebrand factor was high. And this is an indirect indication of probably there is inflammation. So we treat this patient with immune suppressive medications. He showed response at the beginning. In terms of clinical, at least he had no recurrence. And also the von Willebrand level went back to normal. Then after giving him like mycophenolate mofetil, he didn't show any further improvement, and he keep having like transient ischemic attacks. He went to USA Johns Hopkins, and they concur with the diagnosis, and probably this is a vasculitis, but it may be moya disease. Ultimately, patient received another cycle of cyclophosphamide, and he showed again an improvement, especially with the normalization of von Willebrand. The patient started to have, after 2 years, like the typical branches of the puff smoke, which happen in the moya disease. So in this case, really, we don't know if it was started as vasculitis or if it was a moya disease from the beginning, because the lesion is really not classic for either, because of the involvement of the cervical internal carotid. Differentiation, the visual wall enhancement, it could happen or could occur in moya disease, but usually it's like a REM enhancement. But if there is a clear enhancement with because the radiologists, they have like a grade for this. This may suggest small vessel vasculitis, large vessel vasculitis. And if you have high von Willebrand, this may indicate again vasculitis. But I agree, sometimes it's difficult to differentiate between moya disease and a progressive large vessel or medium vessel vasculitis. The biopsy in moya disease usually it showed non-inflammatory lesions. But why those patients with moya disease have like a REM enhancement? And in fact, some of them, not all of them. The classic or the first study about visual wall enhancement in moya disease, it revealed no enhancement. But subsequent studies showed some patients, they may have like RM enhancement. And sometimes it could be really very difficult. The site of a brain biopsy, is it important? Well, the site, you go first by the lesion, if it is approachable by the neurosurgeon. So you go for the lesional biopsy. If the neurosurgeon said like it's deep and they cannot, you could take non-lesional biopsy from the non-dominant part. No, there is, unfortunately, there is no rule of MRI visual wall in a small vessel disease. The only way, unfortunate, is a biopsy. I think probably there is, if there is a radiologist with us, they could comment, or I mean pediatric neurology, if they have any comment, they could. Any other questions? Also, those patients, they may present, I shouldn't forget the other specialty like an emergency and also ICU. Those patients, they may come to the ICU, and in fact, they may have a massive infarction with secondary brain edema, and the protective brain measure should be taken in those patients. In fact, those patients, they may present to a neurologist, may present to a neurosurgeon, they may present to ICUs, they may present to rheumatologist or psychiatrist as initial presentation. So all of these people are helpful in the diagnosis, or infectious disease also. Okay, as long as there is no more questions, we'll go to the this case. In fact, this case, we saw her almost 1 month ago. So she's a 9-year-old healthy girl who had otitis media, treated with amoxicillin for 2 days, and then presented with history for frontal headache, fever, and seizure for 1 day. The frontal headache was sudden, mild to moderate. 3 times seizures, each lasted for less than a minute. It's a generalized tonic-clonic with eyes uprolling, associated with tachycardia and desaturation, typical for seizure or for convulsion. The fever was documented as 39 centigrade, and she continues to have fever for subsequent 4 days inside the hospital. At the beginning, she had history of vomiting, abdominal pain, and diarrhea for 1 day. However, abdominal pain continues for another 3 days in the hospital, then resolved. She had, by asking the history, she had a recent aggressive behavior, especially at school. And this is something her parents, something new. The family history was unremarkable. She had raw milk ingestion and contact with animals. And this is, I'm giving just the positive things. In examination, she looks ill, but not toxic or in distress. She was conscious, alert, no lymphadenopathy, and no skin rash. Her examination of the ENT, chest, cardiovascular were remarkable. Abdomen, there was a generalized tenderness, but there was no like organomegaly. MSK was absolutely normal, and the CNS exam by our colleagues, neurologists, it was normal. She doesn't have any neurological deficit. She has normal tone power reflexes, normal higher function, and also the cranial nerves. And importantly, she doesn't have or didn't have meningeal sign. Her initial investigation, she was admitted to rule out encephilitis or meningeoencephalitis. Her initial labs, WBC was 7.24, hemoglobin 134, and the platelets was okay. Her ESR was high, 42. However, her C-reactive protein only 1. Electrolytes, glucose, liver function tests were normal. CSF study was done, and the glucose was a little bit lower, 2.1. Protein was high, and the CSF in the or WBC CSF 274, and it's mainly lymphocytes with 122 RBCs. The cultures from the blood, CSF, and urine all were negative. And also the CSF multiplex study for various bacterial and viral, including the herpes study, were negative. Brucella serology, because of the contact with the animal, was negative. We did at the beginning with this diffuse abdominal pain, amylase and lipase, just to check for a systemic disease, and it was normal, and the quantiferon was negative. CT brain and venogram were unremarkable, with no evidence of acute sinusitis. MRI showed non-specific T2 flare hyperintensities in the right frontal subcortical white matter, right globus pallidus, and right middle cerebral peduncle. No associated diffusion, restriction, or enhancement. No infarcts or bleed, no leptomeningeal enhancement. And the radiologist, in fact, our colleague in the pediatric radiology, their impression, probably this is a small vessel disease. However, other causes cannot be excluded. So this is the MRI. In fact, I sat with our radiologist, and he showed me this one. So this is the one in the globus pallidus, and this is the one in the cerebellar peduncle. And there was another cut, but I didn't put it, in the frontal subcortical area with a clear hyperintensity lesion. So we did a von Willebrand factor, and it came very high, more than 199. So what do you think the diagnosis? Oh. What do you think the diagnosis? So I will receive your answer in the chat. So we were called, is this a small vessel vasculitis, primary small vessel vasculitis? Or if you want for any further investigation, FCA, this abbreviation stands for what? Sorry. FCA, focal cerebral arteriopathy, you mean? No, it's for sure this is not focal cerebral. Why? Because focal cerebral arteriopathy or the non-progressive Cns vasculitis, they have unilateral lesion, and it's ischemic lesion. Our patient is having like multifocal, and it's enhancing lesion, and no evidence of ischemia. And the patient, in fact, presented with seizure, usually focal cerebral arteriopathy presentation as a stroke. This patient presented with seizure, with sort of a neurocognitive involvement, and some behavioral changes. And also, I shouldn't forget our colleagues in behavioral pediatric. In fact, almost the subspecialty are involved with these cases, because sometimes it's really difficult to diagnose. So I am waiting. Those who understand the lecture, so what do you think the diagnosis? My question is just for fellows. Vasculitis secondary to viral infection. We did the multiplex, and the other thing, the degree probably of the elevation in the CSF of WBC is probably higher than what you expect in viral infection, right? Angiography negative, yes, this is maybe a diagnosis. That's why we saw this patient. Neurobichette, excellent. Neurobichette, in fact, when we went back, we asked specifically for recurrent oral ulcer, for genital ulcer, for skin manifestation. We sent this patient for the ophthalmology, and all of these are negative. Her HLA-B51 was positive, but what I found in our population, there, because in our lab, when we send for any HLA, they will do HLA-B51. So we found it quite positive in a good subset of patients, and they don't have Behçet's. Secondary causes of vasculitis infection mainly. Okay, good thinking. But what infection? This is the question, not because I know Shahad, you know the case. So it's the question to the others. لا تجاوب يا طلال. ADEM, the high von Willebrand, this is, and also per our radiologist, it's not the typical features of ADEM. And the high von Willebrand, this will support vasculitis. In a study done, they found no patient with ADEM have have high von Willebrand, while frequently found in patients with small vessel vasculitis. يلا يا جماعة. طيب خلاص you'll diagnose, you'll start immune suppressive medications. طبعا what about MR angio? Yes, it was done, and we did even visual wall, both normal. So it didn't show any evidence of large vessel or medium vessel vasculitis. In fact, the MRI findings that I showed you, it indicate small vessel disease or small vessel vasculitis. So mainly primary. Mimickers should be ruled out. Excellent. Like what? Mimickers of, there is a mimicker for medium and large vessel vasculitis, and there is a mimicker of secondary or small vessel vasculitis. So you have to rule out secondary causes before saying this a primary CNS vasculitis. Okay, any other further Kawasaki? The patient didn't have other features of Kawasaki. And again, rarely Kawasaki would have small vessel vasculitis. PAN, there are no, in fact, when we saw this patient with abdominal pain at the beginning, we said maybe systemic vasculitis, but ultimately everything has resolved. Neuronal antibodies like anti-MOG, excellent. So we ask our colleague to send it before, because we have to exclude all secondary causes of CNS vasculitis before sending this patient to brain biopsy. So anti-MOG was sent. CNS vasculitis secondary to brucellosis, but her brucella serology is negative. Okay. Any other thought? Probably there is no much time. So when we saw this patient as part of ruling out, the duration is very short. Absolutely, you are right. However, I have seen some patients with a primary small vessel vasculitis, and the duration is so short. They presented with acute seizure. Some of the patients, they have intractable seizure with a status epilepticus. But yes, with a very short duration, we have to make sure that we exclude other differential diagnoses or secondary causes. So we did, I mean, because of a girl, she's a girl, we want to make sure that we are not missing other autoimmune diseases like lupus, and all came negative. HLA-B51 came positive, which is associated with patients with Behçet's disease. But we have seen frequently patients with other conditions and they have HLA-B51. So we sent for Brucella CSF PCR and it was positive. And yes, the diagnosis was neurobrucellosis, even if the serology is negative. In fact, what's the clue from this case to neurobrucellosis is the high WBC in the CSF. Usually in primary CNS vasculitis, they don't have this high CSF WBC, and also the glucose at the lower side. And this patient, so this patient is having a secondary vasculitis secondary to neurobrucellosis. So I'm bringing this case just to note the difficulty in diagnosing those cases and to make sure that you ruled out everything else. Also, we sent for a quantiferon and 40B PCR from the CSF and it came negative because TB or isolated CNS TB may mimic primary CNS vasculitis. And thank you very much. If you have any questions, I am happy to answer. Excellent, Safiya. You are right. CNS vasculitis secondary to brucellosis. Any questions? We'll give 5 minutes. I am sorry, it may be this is a bit difficult, especially for maybe pediatric residents or interns. It may be a little bit difficult. Yes, it was managed by ID. Which one we start first? In this patient, she was started on anti-Brucella. I should say that in some patients, you may need a steroid. You may need a steroid to inhibit the secondary vasculitis. So we treat the trigger. If there is no improvement, we may add a steroid along with the antibiotics. What was the management? So she is, in fact, she just diagnosed recently and she's on antibiotics for Brucella, doxycycline and rifampicin. Do you recommend to repeat in patient presented with? Yes, of course. CSF study is a mandatory for patient, I think, with encephalopathy or vasculitic picture, because we need to find the evidence of inflammation. So also measuring opening pressure is very important, plus the regular investigation. Thank you, Dr. Fahad. Thank you for your attendance. Any questions؟ ترى يمكن في أحد ما لحقت عليه إذا كان is a question. طيب. Okay, Fatima, The diagnosis was dependent on CSF analysis or response of brucellosis treatment. Yes, I will refer probably repeating CSF to our colleagues of infectious disease. I'm not sure if they regularly do like a CSF analysis after treating brucella, but this patient should be carefully clinically monitored and also MRI. If there is no improvement, you may repeat CSF. And if still, you may consider giving a steroid. This case, in fact, the peculiar thing that the serology was negative. This is what make everybody thinks it's unlikely to be brucella. But in fact, this patient was referred to us. Could this be like a primary Cns Vasculitis? Especially the MRI is suggestive. But the high WBC and the CSF, it was the clue. So the diagnosis was dependent on CSF or response for brucella treatment. I think I answered this question. Is it clear, yeah, Fatima, the answer? So the PCR and CSF for brucella was positive. And this is why this patient diagnosed with the neuroprocellosis. The PCR from the CSF was positive. And we are still waiting for the culture because, you know, brucella, it takes time to grow in cultures. طيب في أي سؤال يا جماعة؟ Is it possible this lecture can be loaded so we can get benefit? I think this lecture is recorded, so yes. But for the neurology and rheumatology fellows and residents, pediatric residents, and pediatric radiologists, and all the pediatric subspecialties. Yes, Buthaina, thank you first for attending. I would not say we have, now we are collecting like a cohort of our patients who have CNS vasculitis. Most of them non-progressive. Few, they have a progressive, and same thing for small vessel vasculitis. The only patient diagnosed with the small vessel vasculitis, only one patient, and she had the typical features of small vessel vasculitis. We do most of the workup at our institution. However, the antibody panel in the CSF, we send it outside. Do you consider genetic studies? Yes. In fact, this patient, whom I told you she has a small vessel vasculitis, based on biopsy, when we send, and it was in fact sent by our colleague in neurology. So the credit goes to the our neurology colleagues. They send whole exome sequencing, and it came positive for a pathogenic mutation for HLH. And this patient is having only primary CNS vasculitis, no other features of HLH, and even in the biopsy. So we consulted experts in the, I think, Boston. They report few cases of HLH, whom they present with demyelinating disease. And in fact, they said, yes, this vasculitis is secondary to HLH. And this patient has to go for bone marrow transplant. And we sent this patient for bone marrow transplant, and now is being worked up. So I think I will do HLH panel for every patient this is my personal opinion, with, or at least patients who do not respond in the appropriate way, either to demyelinating disease or CNS vasculitis, then I will send the genetic study. يعطيك العافية بثينة. If there is any comment, بثينة أو other colleagues from neurology قبل ما أطردكم وأقفل. أمزح معكم ترى. يعني خصوصا يعني some people يمكن ياخذونها serious خصوصا مع الحجر الأيام هذه. If there is any questions. يعطيك العافية يا محمد. طيب, I will wait for probably more 3 minutes if there is any question or comment. Oh, يعطيك العافية دكتور أمل. And thank you for attending this session. Thank you. طيب, I think since there is no further questions, thank you very much for your attendance, and I appreciate that, and hopefully you enjoyed the session, and see you inshallah in next sessions.